You could not find Dr. Moir?
He's not here, sorry. So
okay, our last speaker could not be identified or found. So we have to cancel this, his presentation. We still have a little bit of time for specific or also for more general questions or comments, if you like. Yes, please.
I keep on running, it's no problem.
This is not my field, and forgive me if you covered this when I came in a little bit late. Someone had bent my ear. The difference between Chagas and sleeping sickness and the trypanosomes, what is the primary difference between the two? Because Chagas doesn't seem to go into the central nervous system, but it goes into a lot of the organs, whereas the other trypanosomes seem to go into the CNS, and I haven't seen them in the organs. And if this is too basic, please just cut me off. But I'm curious how they're going through the blood-brain barrier and what kind of damage are they producing. Because over time, you end up with a sleeping sickness, and it's very hard to kill these after they get into the brain. Could you just comment on that?
Well, I think that Dr. Reto could be much more better suited than me to answer this question, because I'm not a parasitologist and I do not know about the sleeping sickness.
And during the last 20 years, I devoted to discover new drugs for sleeping sickness, especially for this second stage where the parasite is in the brain. Well, the parasite actively goes through the blood-brain barrier without causing too much damage. And it's not that first the blood-brain barrier is damaged and then the parasites are sort of flushed in. That's not true. They actively go through, and they also can actively come out again. Yeah. The problem is that most drugs are not going through the blood-brain barrier. Many excellent drugs, they are too charged and they just don't make it. So here, especially with drug delivery systems, there would be an open field. Now we are lucky. I showed in my presentation that there are two new clinical candidates. These are the first since about 40 years. And they both have a good CNS penetration and kill the parasite in the brain, fexinidazole and benzoxaborole. So this is great. And this is also a major difference between the South American trypanosome and the African trypanosome. By the way, the only thing in common the two trypanosomes have are the name, yeah. Genetically, they are very distant, they are very far away. And also the whole cycle is completely different. The drugs you use are different. Everything is different. Somehow they look almost the same. Mm-hmm. A bloodstream trypamastigote looks very similar.
But can I just push this a little bit further along? Because one of the things that I was curious about is I do a lot of work with microglia in the brain. And the Kupffer cells in the liver are very similar to the microglia in the brain. And to take this question one step further, do you see the trypanosomes that are going into the CNS interacting in a similar way with the microglia in the brain as the trypanosomes that are going into the liver interacting with the Kupffer cells?
You mean the plasmodia going into
the liver? Sorry.
Yeah.
Sorry.
Yeah. Well, that's an interesting question, yeah. I cannot answer, but there might be a similarity, yeah. Georgette, there's a question there. Or a comment. We are open for everything, ideas, comments.
So with the neglected diseases, we must use the oral route for drug delivery. I suppose because the IV with healthcare infrastructure problems, you can't really, inject all the patients who come. But the challenge we have with the nanoparticles is getting enough of the particles to cross the intestinal barrier, loaded with enough drug, whether it's an antibiotic or antimalarial, in order to give us the therapeutic effect. So I wonder if in some of your nanoparticle designs, you're incorporating strategies to increase particle uptake, like with the Trojan horse that you showed there. Do you think it's a challenge in terms of getting enough of the particles to carry the drug into the bloodstream?
That I think would be like the next step, because we first started our research by trying to design targeting strategies, which we thought it would be the most complicated. And now, of course, after this step seems to be already behind us, because targeting is not so crucial. Now, the next thing we have to deal with is, as you say, finding ways of delivering sufficient drug amounts into the, in this case, into the bloodstream, if our target cell would be the erythrocyte. And now I think that's the key point, that probably we have to start forgetting the erythrocyte as the target cell for malaria, and thinking about other target cells, which are maybe less abundant and more easily targeted, possibly, and mainly new strategies. So probably also we have to have a switch and start thinking about classical antimalarials, in the sense drugs that target some metabolic activity, of course in the red blood cell, but even in the mosquito stages. And maybe we have to start thinking about new ways of action of future antimalarials. I say this, I have of course something in mind, but we are trying to patent it, so I cannot say anything more there. Hopefully next year, if I can come, I can tell you what this new type of antimalarials might be. But what I see also, the consensus in the malaria community is we cannot deal with infected red blood cells. We really, even in the vaccine, they have realized the vaccine that is being developed next door from our lab, it will be not effective, or not 100% effective from the beginning. And obviously, with time, it will decrease its efficacy. And now it's a consensus that you will need vaccines also against transmission stages. And they are the next vaccine generation. It will be a combination of red blood cell antigens and also transmission stage antigens. So clearly, probably to deliver sufficient amount of drugs, I think it will come more through targeting other cell types rather than through trying to develop nanovectors that can encapsulate a lot of drug. Okay, no more comments. So I think we are all happy if we close this session a bit earlier. We have heard very exciting new developments, I must say, in diagnosis towards drug delivery. I think there is most potential, and also in vaccine delivery. There's no doubt there's a lot of need. And sometimes I feel that also this R&D for these new tools in neglected diseases is itself neglected. But we have to overcome this. We have to overcome this, and I believe, since there is this London Declaration and the will to eliminate 10 neglected tropical diseases, I can guarantee you there is also funding there, yeah. And the Gates Foundation is really very keen in eliminating these diseases. And it may not always apply that everything has to be cheap. you know, everything has to be cheap when the end user is supposed to pay for it. But currently all the drugs are being donated by major pharma companies. And for instance, for African sleeping sickness, this is also one of the 4 diseases on the radar for elimination. This is a top candidate, I tell you. There are only about 7,000 registered patients in Africa right now, maybe an additional 15, we do not know. But not much more. We know where they are. And so we do not have to produce millions of packages of drugs, you know, but just drugs for maybe 20, 30,000 patients, good drugs. And with these 2 new candidates, I can tell you these are oral drugs, simple to apply. I think we have all the tools, yeah. And then it doesn't matter if a treatment costs $5 or $50, yeah, because the number of patients is low, and the Gates Foundation will invest the money. But for malaria, it still is different. Malaria is not per se a neglected disease, and the idea is to keep it sustainable and to come up with new drugs which are being produced locally and which are affordable for the population. I think for malaria, this concept is important. But for some of the other diseases, I think the price of the drug is not so important. It's more important to really tackle this elimination and do it, if possible. So these are my thoughts, and I believe that this session stimulated a lot of good discussions, and I hope these discussions will continue during coffee and during evening events and so on. And with this, thank you very much for all of you. And I close this session.